hear me?
Yes.
Okay.
Yes.
Good evening, everyone. So thank you, Professor Watanabe, for kind introduction. And thank you, William. So thank you for inviting me. So today I'm talking about the technical knack and pitfall in laparoscopic surgery for obese patients. So now we are in a difficult situation due to COVID-19 pandemic. So Japanese situation is getting better, but we cannot be off our guards. So I'm start my presentation. So have you been pushed into the corner during the surgery? So we are sometimes faced with so difficult situations. So in difficult situations, so is he your friend? So if so, maybe you can get happier. But such a dreamy solution to our days never found. So what helps us from difficult situation? So it's so our usual surgery. So this is my personal view. So in colorectal cancer surgery, so mobilization holds the first place. So in the mobilization, so layer-oriented surgery is the most important. For safe and precise surgery, to keep the appropriate layer is the most important. So resulting in less bleeding. So reddish operative field brings a loss of quality. It's simply a bad habit. So we have so some difficult situations. So patient fractures, including so fragile tissue, so obesity, and adhesion fibrosis in the redo surgery, and the narrow pelvis in rectal cancer surgery. And so tumor factors, so massive lymph node metastasis, and huge tumor, and T4P tumor. So today I want to focus on obesity. So I show a video, so right away. So first is a 84 years man, so who underwent so right hemicrectomy for ascending colon cancer. So BMI was 38. So it's in Japan, it's very obese. So preoperatively, we have to confirm the where the idiocolic artery is running. So above or below the SMV. So I show video. It's augmented fat is so we have to consider. So what is the fat belong to? So mental fat or so mesocolic fat. So we have to cut the border of the fat. So this is the mental fat, and this is a mesocolon fat. So we never divide the fat. It's resulting in bleeding.
Thank you.
We have to see the border of the fat. We try to divide the border. Surface is difficult to distinguish the border sometimes. But he's so easy to distinguish. So lastly, we cut the surface. So if we try to, so every time, so in every operation, it becomes easy to distinguish the fat border. So less bleeding. This is the duodenum. So we have to keep the layer. This is the pancreas head. This is so accessory right colic vein here. So keeping a layer so brings less bleeding. This is a retroperitoneal approach. So mobilizing the right column. So to keep the yellow and whitish view is very important, not reddish. So ureter is running here, around here. But such a fatty patient, we cannot see. We don't need to see. This is duodenum. The assistant never so put strong. Very gently using a garden. So never destroy the fat tissue. And divided the fat tissue. And this is a pancreatic head, the access of right colic vein. Maybe this is right colic vein. So it's connected to the subcranial space. So next, move to the lymph node dissection. So ileocecal, so vessel is running here. We have to find the SMV here. This is the root of the IMV, ileocolic vein. So ileocolic artery is running here. So above the SMV. And expose the root. This is a Garza is putting up above the pancreatic head. This is the artery, and divide the vessel first. The next divide the artery. And dissection is up to along the SMV. So this is a right colic vein. We confirmed the CT. So this patient had a right colic artery and vein. This is a pancreatic head. So near the gastrocolic trunk. This is a right colic artery. This is a pancreas. And we decide the cut line of the transverse colon. And this is the middle colic vein here. The root of the middle colic vein. But in this case, a tumor is located in the hepatic fracture, and only a right branch is divided. This is the right branch of the middle colic artery and vein. And we divide it only a right branch. So because of the so much fat tissue, So it is difficult to divide it accessory right choric vein. So from the cranial view, we lastly divided the accessory right choric vein. So after lymph node dissection, it's a usual view in the right hemicolectomy. So this is the current status of obesity in the world. So Asian people are so skinnier than Western people. So in Japan, BMI more than 30 is only 4%. And so Philippines, Singapore, Indonesia, so around 6%, and Thailand and Malaysia more than 10. But in Western country, so more than 20, and United States 37. So very tough situation. So this is the actual data of our hospital. So we work in a favorable environment. So, but sometimes we encounter the obese patient. So cautionary points in obese patients are, so don't break the fat tissue. So identify the true attribute of each fat and grasp fat tissue gently. So never give a strong pull. And if not, so easily breathe. So we cannot desire so wide and excellent view at once in fat ocean. So in fat ocean, so we can make only a limited view. So connecting a reliable piece continuously in the limited view is very important. So this is the last video. So 43 years old man, so underwent sigmoidectomy. So BMI was 36, like this. So we use a standard 5 poles. So omental ocean. So assistant put up the IMV by the right ligament. So peritoneal was cut the right side of the IMV. So here is the easiest place to enter the holy plane between the mesocolon and the geratas fascia. So medial mobilization of the descending column mesentery is towards the outside. So the aim of this step is not to make so large space, so not but so goal of the mobilization. So to catch a reliable layer is the most important. So during this step, the IMV should not be divided. So make a so reliable space. And keep a layer. And next, we approach to the root of the IMA. So below the root of the IMA, the proper layer above the superior hypogastric nerve plexus is cut. We divided the right side of the aorta, and we expose the hypogastric nerve, superior hypogastric nerve plexus. and divided the right side. The root of the IMVA is exposed. Here is a root. This is an plexus. This is a readable layer. And we divided the IMVA in the early stage. So we approach to the root of the IMVA from the right side. So we can understand this is a deep layer and this is a shallow layer. So we have to connect these two layers directly in the short distance. So this is an act of less bleeding. So we have to come back to the goal. So this is our goal. From a deep layer to a goal, we have to go back directly. At this time, the assistant faucet put up the stamp of the IMVA. So this wide space. So IMV makes as a peer. So next we divided the IMV and the LCA. The mobilization is going to the cranial side. Here is the pancreas. This is the pancreas, and we put the gazer on the pancreas and move to the lateral mobilization. Only the same membranes remains. And the omentum is detached from the transverse colon, and the spring flexion mobilization is completed. And next we move to the pelvic phase. The assistant, caudal forceps put up the root of the IMVA, and along the, put hypogastric nerve pressure, the retrorectal space is open. This is a hypogastric nerve pressure, and this is a nerve, and this is the left side, and mobilize the rectum. So no bleeding. And so mesorectum is divided. So using the ligature, so we have to confirm the rectal wall. So under the direct vision, this is SRA divided, and the left side. And the rectum is divided. So this is not reddish. It's a very safe surgery. So ureter is not exposed. So who can identify the layer? So overcome the fight against obesity. So my mentor, Professor Morier, taught me so surgery for obese patient is a great training opportunity given by heaven. So it's a good time to show our skill. So everyone can do well in an easy case. So professional can do usual surgery, even in a difficult case. So he taught professionalism as a surgeon. So thank you for your attention.